The patient that I'm going to share with you, the experience we have with this patient is 54 years old, male, diabetes mellitus, smoker, history of previous stroke. And as you can see, he had recent onset atrial fibrillation. That was what triggered his cardiac investigations. He was found to left ventricular ejection fraction, slightly depressed, 40%. And on these grounds, he was investigated with coronary angiogram. He was found to have this anatomy, basically a tandem stenosis in the left circumflex, the bifurcation with this small diffuse marginal, this distal diffuse disease, and also this tight stenosis in the PDA coronary artery. Now, of course, the LAD was not affected, but yet we calculated the anatomic syntax score and also the syntax to score that gave us equivalent mortality in the long term. In any case, it was decided to perform FFR guided percutaneous revascularization. So basically, we have here the procedure. We started using radial approach, 6 French EBU catheter. Now, one interesting thing is that I'm going to show you the new wire, the COMET wire. It's a wire by Boston Scientific, very interesting. It has fantastic properties to be used in this context of multi-vessel or challenging disease. You can see how nicely you can perform the bend, and it's not a surprise actually, because the technology that this wire incorporates comes from Asahi. That is one of the most important and modern manufacturers of guide wires in the world, very well known to those who are performing complex PCI like CTOs. And so you can see here, for example, how you can navigate very easily with this type of wires. You can explore all the different branches. It has a fantastic torqueability and steerability. And the tip has also this double helix, double coil technology that is proprietary of the Asahi guide wires and enhances all these properties of steerability. Now, okay, well, the patient may look that it has gone into supraventricular tachycardia, but actually it's because the firm has been accelerated a bit to show the FFR, and you can see how nicely the interface detects an FFR that is positive in this patient. And now I'm performing a pullback that is, of course, very important to document where you have a big jump. I have noticed that this is the place where you have the biggest modification in gradient. I film it to record what it is, so it is clear that it's mainly the proximal stenosis, but you can see when generalize the tracing that actually you should try to treat both the distal and the proximal stenosis. So this is the way that you unlock actually the wire. It's a fiber optic system, so the good thing is that you don't have any connectors in this part, so makes it beautiful for inserting over it any device, any balloon or an IBUS, like in this case. The console, the interface is actually the same that you use for IBUS. This is an optic cross image of the vessel that reveals that, as a matter of fact, as it happens in many occasions, you have a much larger vessel structure that you would suspect from these diffusely narrow vessels. So that on that grounds, we performed implantation of a synergy stent, 2.25 and 2.5 for the proximal segment. You can see that we are using here imaging enhancement to make sure that we are overlapping the stents in the right point. And it illustrates very well the type of technology that we are using nowadays every day in the cath lab. So these are the results that we obtained with the IBUS. Assessed again with optic cross, we realized that it was less than 5 millimeter squares in the proximal section. We go for a 3.0 balloon. Again, with enhanced imaging, we can see the areas that we are dilating. So this is constitutes an additional guidance for our intervention over the stent. And this is the result that we obtained after this optimization based on IBUS. So if we, as you can see now, we have a much larger luminal area. If you compare pre and post optimization, you can see that we have moved from 4.66 millimeter squares to 7.21, something that was not evident in angiography, but now we reveal with this. Now, the good thing of this is it's an optical wire, so you can connect it without concerns of whether the wire is wet or not, and immediately you restore the capability of steering the wire when it is connected. So the good news is that we have completely restored the conductance of the vessel. You can see the FFR post is 0.93. So it's an excellent physiological result. Also, from the perspective of IBUS, it's an excellent result. You can see the console allows interrogation of a specific segment of the tracing to make sure that you have no pitfalls and that you can see nicely the waveforms. And this is the result that we obtained in the left circumflex vessel. Much larger extent than that you usually would have used, that you can use safely on the grounds of IBUS imaging. Fantastic physiological result. So we move now to the right coronary artery. Again, same wire. So the good thing is that it keeps the properties. There was no need to perform even normalization of pressure. There was no pressure drift. We cross the RCA. We interrogate the vessel again with FFR. And as you can see here, again with this has been accelerated. You can see that this tight stenosis is actually associated with an FFR of 0.88. And when we pull back the wire back to the catheter, we can see that there is a persistence of the calibration. There is no pressure drift whatsoever. So basically, it's a fantastic tool for assessing very quickly several vessels in the context of multi-vessel disease. You can use it as a workhorse device. We use it for implantation of stents, etc. And actually, the quality of the tip of the wire is very good. After all this work, we examine the tip of the wire, and as you can see, the bend is preserved. There is no damage to the tip. So, in a way, we have an excellent tool for this type of cases. So, the learning points of this case is that physiological interrogation of this vessel, of this patient, simplified treatment, because actually there was only need to treat one of the vessels, and the IBUS information was complementary to what we obtained with FFR, because we could not only implant safely a larger stent that you would expect from angiography, but also we optimized the result in a situation where we had calcium. We also knew that there was some calcium, so we performed pre-dilation based on the IBUS findings.